A 62-year-old man has a sudden onset headache and visual disturbances. He is in hospital as he had a Hartmann's procedure 48 hours earlier. He has homonymous hemiopia with macular sparing and visual agnosia. He has no other neurological deficiency. Which is the most likely location of the lesion? A, the anterior cerebral artery. B, the anterior inferior cerebellar artery. C, the middle cerebral artery. D, the posterior cerebral artery. Or E, the posterior inferior cerebral artery. I'll give you about 30 seconds to read the questions and then we will go through the answer. So the answer to this question was D, posterior cerebral artery. Posterior cerebral artery, or PCA strokes, can present with contralateral homonymous hemiopia with macular sparing and visual agnosia. Visual agnosia means the inability to recognize objects and faces. PCA strokes often present with mild, vague signs and symptoms, and this can delay diagnosis. It's important to remember that this patient is at high risk of clotting due to their recent history of surgery and immobility. If this patient presented, they would warrant an urgent neurological review. In the next slides, we'll go through in more detail why this was the correct answer. The question stem required you to infer that this patient was having a stroke, and we're now going to discuss stroke as a topic in more detail. Stroke is defined as an acute neurological deficient lasting more than 24 hours and caused by cerebrovascular etiology. It is subdivided into ischemic stroke, and this can be caused by a vascular occlusion or stenosis, and hemorrhagic strokes. These are caused by vascular rupture. Presentation of stroke can vary, but tend to present as a sudden onset of neurological symptoms, and this tends to suggest a vascular cause. Stroke symptoms are typically asymmetrical. Common symptoms include limb weakness, facial weakness, dysphagia, or speech disturbance, visual field defects, sensory loss, ataxia, and vertigo. Risk factors for stroke include a previous stroke or TIA, atrial fibrillation, carotid artery stenosis, hypertension, diabetes, raised cholesterol, a family history of stroke, smoking, obesity, vasculitis, thrombophilia, and the combined contraceptive pill. So, diagnosis of stroke. When querying a stroke, a focused history should be taken. This includes, if possible, a collateral history from family and friends. The history taking should focus on the timing of the event. What was the time of onset? Did the patient wake up with symptoms? For examination, clinical examination is important for giving us information. A neurological examination is important to establish, does this fit with the stroke diagnosis? You can also examine to establish, is there an underlying cause and have any complications arisen because of the stroke? The picture on the right of your screen demonstrates the key examination findings to consider when examining a patient for stroke. For investigations, bedside investigations to be done include a blood glucose. This is important to rule out hypoglycemia. This is because hypoglycemia may present with stroke-like symptoms or signs. Routine bedside observations must be done, including a blood pressure, pulse, and oxygen sats. An ECG can also be done, as this may show atrial fibrillation. Blood tests recommended include a full blood count, CRP, Usinase, fasting lipids, clotting, and blood gas. For imaging, the most important imaging is a head CT to be done as soon as possible. Indications for immediate brain imaging are outlined in the NICE CCARES red flag guidance. All patients with a possible stroke should have a CT head done as soon as possible. It's important to note CT head findings are often normal in the first few hours following an ischemic stroke. Brain MRI can also be considered, and this is the preferred investigation if a posterior circulation stroke is suspected, as it provides better imaging of the posterior fossa. This picture demonstrates the symptoms and signs associated with different strokes. On the picture, you can see the circle of Willis. This is a critical arterial network at the base of the brain. Different arteries supply specific brain regions, and infarcts lead to characteristic stroke symptoms. For example, an anterior cerebral artery infarct typically presents as contralateral leg weakness, typically more than the arm, and expressive dysphagia if the dominant hemisphere. The Bamford classification of strokes. The Bamford classification is a clinical system for classifying ischemic strokes based on symptoms and affected vascular territory. It helps in predicting prognosis and guiding management. Strokes are divided into 4 categories. Number 1 is the total anterior circulation stroke, also known as TACS. This affects the anterior and middle cerebral artery territories, and it presents with 3 key features: unilateral weakness affecting 2 or more of the face, arm, or leg, higher cortical dysfunction such as dysphagia or neglect, and homonymous hemianopia. Total anterior circulation strokes carry the worst prognosis, with 60% mortality at 1 year. Number 2 is partial anterior circulation strokes, also known as PACS. This involves a smaller region within the anterior circulation. Patients have only 1 or 2 of the TACS features, or an isolated higher cortical dysfunction. It has a slightly better prognosis, with 55% of patients regaining independence. Lacunar strokes affect the deep brain structures, such as the internal capsule, basal ganglia, and pons. These strokes do not involve higher cortical dysfunction, but present with pure motor, pure sensory, or mixed sensorimotor deficiency. Some specific symptoms include ataxic hemiparesis and dysarthric clumsy hand syndrome. And finally, there is posterior circulation strokes. These affect the brainstem, cerebellum, and occipital lobe. It presents with a mix of symptoms, including motor and sensory deficiency, cerebellar signs, including ataxia and vertigo, and visual disturbances like homonymous hemianopia. Understanding the Bamford classification is a high-yield topic, and it's essential for stroke diagnosis and prognosis estimation. Management of stroke. Patients with established stroke should be admitted to the hospital, ideally to a stroke unit. An ABCDE approach should be instituted. Thrombolysis with alteplase or an alternative medication in selected patients with ischemic stroke is beneficial when given up to 4.5 hours after symptom onset. Brain imaging is required before the commencement of treatment to exclude a hemorrhage. Thrombectomy should be offered to patients presenting with a confirmed anterior circulation stroke within 6 hours of symptom onset, or between 6 and 24 hours in a proximal anterior circulation stroke with potential to salvage brain tissue. Again, thrombectomy should be considered in patients presenting with a confirmed proximal posterior circulation stroke within 24 hours of symptoms if there is potential to salvage brain tissue. Thrombectomy should be offered together with thrombolysis unless contraindicated. For antiplatelet agents in acute ischemic stroke or TIA, aspirin therapy 300 mg daily should be started immediately and no later than within 24 hours and should be continued for 2 weeks, after which long-term secondary prevention is implemented, which we'll discuss on the next slide. Just to note, blood pressure control in ischemic stroke. According to the NICE guidance, antihypertensive medication is not recommended unless a hypertensive emergency occurs. In patients considered for thrombolysis, blood pressure lowering to 185/110 should be considered. Secondary prevention of stroke. Secondary prevention following stroke should be initiated from diagnosis. Patient education and lifestyle changes should be discussed, including smoking cessation, physical activity, and optimization of diet. Antiplatelet therapy, typically clopidogrel 75 mg daily, is used following an ischemic stroke. Anticoagulant therapy should be started in patients with atrial fibrillation or atrial flutter. This is started within 14 days of the event in the case of stroke. The risks and benefits of anticoagulation therapy need to be discussed and considered with each patient. High-intensity statins are offered to patients with ischemic strokes, and antihypertensives are offered to target systolic blood pressure of less than 130 or 140 to 150 in patients with severe bilateral carotid artery stenosis. Carotid endarterectomy is offered to patients with symptomatic carotid stenosis of 50% to 99%. It's also important that patients must not drive for 1 month after a single TIA and 1 month after a stroke, provided they've had a satisfactory clinical recovery. For complications of stroke, complications can include cerebral edema, hemorrhagic transformation of ischemic strokes, aspiration pneumonia. As a result, patients should be kept nil by mouth from presentation and should have early SALT assessments, seizures, delirium. There's also long-term complications including pressure sores, falls, malnutrition, depression or psychological problems, and VTE.